So, very good study, but further in the future, if you want to do any other studies, you can compare with phaco-trab.
Yes. Next author we have is Dr. Gauri Gatani. Unexpected visual recovery post trabeculectomy in case of one-eyed patient with refractory glaucoma.
Maximum will ask only one question. Paucity of the time.
Uh, Good afternoon, everyone. So, the case I'll be presenting today is an unexpected visual recovery in a one-eyed patient with refractory glaucoma. So, I present it not only out of academic interest, but also because it still remains to be an enigma as to how visual recovery happened in this case. So a 66-year-old female presented to the OPD with complaints of severe pain and loss of vision only in the left eye since last few days. On examination, I found out that she had undergone trabeculectomy 6 years ago before presentation, and also cataract surgery in the right eye 3 years before presentation. And right eye was on presentation thicycle. So on examination of the left eye, the best corrected visual acuity was just finger countings at around half meters. IOP couldn't be recorded with non-contact tonometer or tonopen. So, but it was very hard on palpation. And the anterior segment showed clear cornea, clear lens, a non-reacting mid-dilated pupil, and an old cystic bleb of Prab located superiorly, and a very shallow OC. But on gonioscopy, I found the angles to be open. The fundus examination showed a 0.8 cupping, while the central fundus was grossly within normal limits. So after few days, when the pressure was brought under control, these investigations were done, and anterior segment OCT showed an anterior chamber depth of 0.68 millimeters and a right and left angles of 30 and 24 degrees respectively. Also, the pachymetry showed a very low central corneal thickness of around 367 micrometers. This is the left eye RNFL thickness, and the peripapillary RNFL area is very thinned out around 52 micrometers. So what we did was, on the first day of presentation, we started full topical and oral and IV glaucoma treatment with IV mannitol 200 cc, tab Dimox to start, and topical treatment of timolol, brimonidine, brinzolamide, latanoprost, and pilocarpine. And after few days within of follow-up visits, the pressure first came down to 55 as shown in the graph, and later the treatment continued over 10 weeks, and this is the graph that despite full topical treatment and oral treatment also, her pressures varied between 11 mmHg to 35 mmHg, and there was absolutely no visual improvement, though she got relief from pain. And she was unable to perform daily activities being one-eyed, so we decided to go ahead with a repeat mitomycin C augmented trab in the left eye to achieve a lower target pressure. And surgery was performed 10 weeks after presentation. So these are the intra-op things. We made a limbal-based conjunctival flap, and 0.2 milligram mitomycin was applied. Sclerotomy was done, iridectomy done, and sutures were taken to secure the triangular flap. We found that there were extensive conjunctival adhesions in that area due to the previous surgery. So I had to take an inferior conjunctival graft to cover the trabeculectomy site with glue. And but tight closure was achieved that day. On post-op day 1, there was hypotony, and choroidal folds could be seen, but sedals was negative. And on the following post-op visits, I was surprised to find that the BCVA improved to around 612, and the pressures were very good maintained. The bleb was functioning, well-formed AC, and this is the post-op picture. Superiorly, there is the old cystic bleb, and superomedially is the new bleb with the conjunctival graft over what we made. And this is the fundus photo of post-op around 4 weeks. And these are the findings of post-op 4 week. There was no significant change in either anterior segment depth or the RNFL thickness. She was able to perform HFA 30-2 as well as 10-2, and these were the findings. So what with my research I could found out was that RGC death mechanism is biphasic, but so even after a primary insult of increased IOP and vascular deregulation, there is a period of reversible secondary cell degeneration, where if you control the IOP, there might be restoration of exoplasmic flow and improved microcirculation, and which might have caused the reversal of visual acuity, but this has been proved only in the congenital and juvenile glaucomas as yet. So in conclusion, I would like to say that reduction in IOP not only had a neuroprotective effect, but also a neuro-enhancing effect in this case, and which I suppose is due to the restoration of exoplasmic flow and improved microcirculation to the optic nerve. Thank you.
So very interesting case. So why was Goldman GAT not done for IOP? You said NCT was not.
Not on the first visit. I couldn't. First visit, she was not cooperative, ma'am. She was very in too much pain. On the follow-up visits, I had done, ma'am, and I've documented over the next 10 weeks.
So do you think the optic disc and visual field are correlating, according to you?
Yeah, the thinning was around 0.8 to 0.9, and visual
But you
field
said
is
NRR was healthy,
NRR seemed vague. Ma'am, it did seem healthy.
so it has
So
to
it is still-
correlate.
Yeah. I even got an MRI done in this case, which I haven't included, and it came out to be normal to rule out other causes.
And why was 10 weeks the waiting time for surgery when she's one-eyed with very
Because
high pressure?
she was already trabeculectomized, ma'am, and that's why I didn't want to touch the patient. And there was hardly any area where I could see that I could operate. So ultimately, I went for a superomedial site, and I had to take a graft inferiorly to cover that area.
Thank you.
Please call.
Thank you, sir.